your hand, we'll call on you and unmute your line.
Okay. So we'll get started. The first slide that I asked Heather to put up and leave for those of you that might have joined early, this is just kind of an analogy that we've been using to try to help us put our whole DSRIP plans in perspective. I think of the DSRIP plan as very much like a book report in high school. And so I think most of you can remember doing those. So the first step, and this is our April 1st application, and that's what these budgets that you're being asked to put together are going to be part of. That's really what you would think of as an outline due to the teacher. Teacher would want an outline like before your book report is due. That's really what our 4.1 application is similar to, related to our DSRIP plans. It's not going to be the final book report. It's not have all the details. It's not going to be driving the actual funding. I mean, it's related to it, but it's more just a high-level outline. How do we expect to manage and run this DSRIP program and all of our projects? So the project plans themselves, and this refers to our 11 projects, each one of those is like a summary of the 11 chapters in our book, is a good way to think of it. Project budgets, which is the focus of this presentation, that's really like a section of one of the chapters of the book, meaning it's going to be one aspect of that project plan for that individual project. So it's just one piece of it. So the budgeting or the cost related to implementing that, just one section, if you will, of a chapter of a book. Then the next thing would be the book report itself. This is the actual DSRIP project plan. This is, we're going to write this over the summer, which we would hate a teacher that asked us to write a book over the summer, or write a book report over the summer, but that's really when the full DSRIP project plans will be fleshed out and developed. A couple bullet points here. You know, this one is for the grade, if you will. This is where we, as a PPS, all of our members, will be outlining, this is our plan for getting through these 11 projects to meet our DSRIP goals. This will outline the metrics, the milestones, all those details that will really be developed in the project plans, working with this group and other groups really during the summer months this year is what we foresee. Some may be a little earlier. You know, it all depends on the project itself. Project plans, at that point we'll have formal contracts with all the partners of the PPS, and I say there'll be like a grading sheet. The Department of Health, for many of these determinants or metrics of how funds will flow to the PPS, many of those are already defined and will be further defined by the Department of Health. So from that standpoint, most of that, you know, should all be known by the time we submit our final project plans. And then key, I think, also is this report, if we think of it that way, should include our ideas on the sequel of this book after DSRIP. So all throughout everything that we're doing in our DSRIP project plan, we're really covering the DSRIP 5-year period, which is seen to be a transitional period. So all of those plans, we need to be factoring in and considering how this is going to be sustaining itself after this initial DSRIP period is ended. And then the last report is the teacher encourages us to cheat. So the Department of Health, they want us collaborating. They want us working with other PPSs. So we are definitely encouraging that. We're encouraging that in our region, and we're doing that at the PPS level. And I think and hope that you'll see more of that as we go. Okay. The next slide, slide 3. This is a $100,000 question, I guess, is how do dollars flow to my organization under DSRIP? And this is something that I thought it would be best to put the actual wording right from the Department of Health. That's why the slide's a little wordy, but just at the highest level, 2 bullet points. During DY 1 through 5, the DSRIP years 1 through 5, the PPS, which is AHI, will be receiving payments from the Department of Health based upon the PPS's performance in achieving the measurable goals of DSRIP projects. So that's how money will be coming into the PPS. Then the second bullet point, how's that money going to go out? So the PPS must establish a plan that specifies how the district funds received will be distributed among the participating providers in the PPS. And this is key, to cover costs and incent the desired behaviors. So I highlighted that, but that's basically saying that that model, that method, the procedure of how the money will flow down to the participants, your organizations, that still being determined, and we're going to be developing metrics and modeling that. But that leads us to the next slide, slide 4. This talks about, and again, this is wording right from the Department of Health. So what we're looking at in our budgeting is we're talking about project implementation costs. And the Department of Health has provided some examples here of what they're expecting implementation costs are. And I think these are useful because it gives a good framework and guideline as you're working through, okay, our organization or our organizations working together are going to develop a particular project under DSRIP. What type of costs does the Department of Health and the PPS consider as implementation costs? So they identified 3 separate project implementation cost types. Letter A, cost for the PPS administration and the PPS level PMO. That's really for the AHIs of the world. That's our cost of administering the program and running the project management, those types of costs, which will be budgeted by the PPS and, of course, approved by all the governance committees here. The next 2 sections are the ones that are really relevant for this group and this process. Letter B is your project implementation costs relevant to more than one project. So letter B identifies that, yes, we recognize there are some projects that, some of our 11 projects, that there's some overlap. So they might not be cost, identified to just one particular project. And they give the example here of the PCMH achievement. So several different projects have a piece of that. And then the third, letter C, on slide 4, that's really what the main focus of these budgets you're working on. These are the project-specific costs of implementing and organizational transformation costs. They identify things such as salaries and benefits, contractor costs, materials and supplies. I know it's just one sentence, but that's the Department of Health kind of high level, what they're identified as potential project implementation costs. And I just highlighted words. Hopefully I spelled them right. 2 key words here, implement and transform. In all our discussions with the Department of Health and with KPMG, who's our district support team, it's really been a focus when we ask about particular costs. They really keep coming back to, is it a cost related to implementing DSRIP or participating in DSRIP? And is it a cost related to the transformation that we're working towards under DSRIP? So I think those are 2 key words that we can all use to help us to say, is this part of DSRIP, is it not part of DSRIP? So I'm going to move on to slide 5, and some of you will recognize these next 2 slides. These are the same slides that we used when we did a presentation in front of one of the in-person regional team meetings. So slide 5 here talks about how do the project budgets fit into the DSRIP budget. And this is looking at it just from our AHI PPS standpoint. So I try to use this visual to show how it all fits. So if you look at the smallest circle, which is blue or purple, depending on your computer monitor, the project implementation plan. I just put an example here. We could end up with one project that we come up with, or you come up with a budget that the implementation costs are $4 million. This would be over the 5-year DSRIP period. Probably heavier in the beginning, maybe nothing in year 5, but that's an example. We may come up with a project budget $4 million. And that needs to fit into the next circle, or oval I should say, is what do we expect, we as a PPS, what do we expect the total budget into that project? So just to clarify, in this example, I'm showing Project 1 funds or budgeting of $20 million, but yet the project implementation costs are only 4. So what's that difference? What's the other $16 million in this example? Well, that $16 million, that needs to cover the administrative costs, so maybe 10%. It needs to cover performance payments, performance-based payments, which again is part of the core focus of DSRIP. So maybe that's going to be 25, 30%. And these are just estimates I'm throwing out there. And then there may be a portion of the project that's going to go to some specific contingencies or the concept of revenue loss. If because of this project there may be certain organizations that we know they're going to have lost revenue as this transitions. So all those different buckets, if you will, of that $20, they're all related to that one project. So I think it's good to clarify when we're talking about one of the 11 DSRIP projects, we have this overall budget for the project, and then we have the project implementation cost, which is what we're asking the group that's on this call to be developing. So I hope that helps put it in perspective and recognize, and we'll show in a couple slides towards the end, that these are all just estimates. We're just looking for, in this $4 million that's estimated here, at this stage for our April application, because this is just the outline for our book report, not the actual book report that we're going to write over the summer. We're really looking for just a high-level estimate. What do we think that project plan implementation is going to be? You know, it could be 200,000. It could be 10 million. We don't know. That's what we're asking the groups. We're asking them to say, here's the plan we've written. Here's the plan that's been conceptualized that we know we want to do. This is saying, what's our estimate of what that cost is to do that over the DSRIP period. We'll talk about that more in some detail, but that's a concept. But by saying that's our estimate for 4.1, we are not saying this is what we're submitting. It's not like a grant, and we're saying, you know, this is what we need to do. And the Department of Health is not going to tell us how those funds get paid out to the different organizations. They're going to pay the PPS based on how the PPS performs, and then the PPS is going to have a model, a logical model that says, okay, for everybody that participated in that, how are we going to reimburse them for that? One way is the direct cost. You have this cost, we're going to reimburse you. There'll be some of that, and then some will be, we talked about, maybe there's revenue that was lost, and it's based on, or there will be performance payments on how all participants do in that particular project. So I know it sounds very kludgy and complicated. I think the key point is that the Department of Health is going to pay the PPS based on meeting specific metrics and milestones. Some are going to be, meeting whatever they define for particular metrics. Some of it may be as simple as you submitted your plan and you have a good plan that outlines what you're going to do. And then the other half of it is, how is that money going to be then dispersed to the different participants in our PPS in a way that covers or tries to cover, reimburse you for the cost, and also incents you to move towards the behavior that the PPS is working towards. Okay, on to slide 6. This is where we just outlined again another way of, another way of looking at how all these pieces fit together. So this is what we envision happening. The first bullet point is that the project teams are going to develop an initial draft implementation budget. Again, this is just a high level, what do we think this particular project, and I know we're doing it differently. For some projects, we might have 5 instances of that same project, and we're asking the teams to put together those 5 separate budgets. Some projects, it may just be one across the whole PPS. So we're just looking for that initial, what's the high level, what we think the estimated cost of it's going to be. I know that's a big ask too, so we recognize that. And then the next step is bullet 2 here. All the project implementation budgets will be accumulated. They're going to be reviewed in total. We'll be looking for overlaps. We'll ensure that everything's qualified, if you will, and that's a loose term, expenditures. So the PPS and with some work groups also will be, looking at all that together. And then the next step, step 3, is we'll be incorporating that into the total project budget process. And this is more like from the slide before, this is where we're saying, okay, we've got all these different project implementation budgets. Say, for example, for one project, all those come up to $4 million. Then we're going to be taking it and saying, okay, how much do we think we're going to need for admin, for performance pools? And these things will be decided not by the PPS itself. It'll be decided by the PPS and the various governance organizations, such as the Finance Committee, the Steering Committee. There'll be various levels of approval that, again, it's still being sorted through, and these things won't be decided on this April 1st application. It's just the, again, the outline for our book report that's being submitted. And then the next step, it will be included in the implementation plan submissions for DSRIP. And then I have the last step, revised as required by the Department of Health. And really the steps after that is, over the summer as the detailed project plans are written, the detailed budgets that go with that will also have to be assembled and put together. So this whole process, and then down to the next level of detail of who's doing what, will occur. And we'll talk about that more too. All right, on to slide 7. I'm just going to mention this one. This relates to the actual template that we provided the regional teams, and we attempted to kind of give you a guideline of the potential costs that we think may be needed for all the costs of projects. So that was the idea, is to kind of have a framework for the regional teams to work through. So this is just some guidelines for that, and I won't go through those. That's more for your reference. Same with slide number 8. These were just some budgeting rules of thumb that really could be used for any budget, anywhere, in any organization. And they just basically say if you're not sure about an item, you're not sure it should be in there, what the amount should be, the general rule is just put it in there and make a note about it, really. And know that at this stage, it's all going to have to be looked at in more detail by organization in the future. So that's slide 8. Okay, on to slide 9. What about revenue? This has been a challenging area, and the reason, again, there's so many words on this is I wanted to give the actual wording that we received here from KPMG, the district support team. This has been an area that, across all the PPSs, all across the state, lots of organizations have been struggling. It's really because it's very much a gray area. And so the general question is, well, as we're figuring out these implementation plans, how do you take into consideration revenue? Now, before I go through these, I do want to preface this that at the end of the day, when we actually have our project plans, these things will be more clearly defined. And also, these guidelines for the Department of Health, these are just kind of recommendations, guidelines. At the end of the day, the PPS itself, through its work groups and its governance, we have to develop our methods and decisions and determinations of how the PPS funds will flow out to the participants. So there isn't going to be a hard and fast rule from the Department of Health that says you have to pay this or you have to calculate cost this way, or you can't include certain items. It's really going to be a collaborative effort, and that's why it's going to be so important, and this whole idea of all the participants in DSRIP and the region working together. Really the goal is to come up with something that we are all comfortable with, it's fair, and it's something that can be, it's going to be transparent, and that everybody will be able to understand what they need to do to move towards what direction and to ultimately receive payments. So that said, that's why I think people struggle, because there isn't a clearly, black and white. You can go look up these questions somewhere. There is black and white. There's going to be black and white as far as how the money comes into the PPS from the DOH, but as far as what happens there and what we can cover for costs out to the actual members, if you will, there isn't going to be only to the extent that we as a PPS develop them internally. Okay, so I know that was long-winded, and you can read through these on your own. I think we'll go through the first one. And again, this is KPMG's response to our question. And our question was, like many people had, if we are, as part of a project, or going to be creating new revenue, or we already have revenue, how do we factor that in? So here's what they gave us for the first bullet point, the general expectation. They said that implementation costs are considered to be costs or the impact of participating in or preparing to participate in a DSRIP project. For projects that require transformation or that will have an impact on revenue, the implementation costs might include costs for operational change that are reducing slower than revenue is being impacted, or for a new service for costs to start up ahead of being able to actually bill payers for services provided. That's quite a mouthful, and it says a lot. And I think the reason it took so long to get this answer is that I'm assuming that they got very specific guidelines for from the Department of Health of how we want to be careful with this. Again, remember, they're just guidelines for the PPS. And then the second bullet point talked about if there was a new service out of one of these DSRIP projects. It talked about basically saying that we may want to fund some of that revenue in the beginning, or lost revenue in the beginning. And then the other point that's been identified in this area of revenue is there may be a new service that is not yet reimbursable by Medicaid or other payers, but it will be in the future before the end of DSRIP. So that's another thing to take into consideration. So I know there's been a lot of questions about this, and we'll probably have some more specifics, but that's the general revenue. Because your organization is participating in DSRIP or one of these projects, and they're going to either lose current revenue or have a loss for some period of time as they're ramping up a new program, those are the types of things we're looking at as, it's essentially like a cost of participating in the DSRIP program. The next slide is just the actual budget template which you have. It's actually not the updated one. We did modify it after we got some more information from DOH. Really the two modifications were we added in revenue at the bottom because, again, it wasn't clear in the beginning how we should treat that. And then also we wanted to, related to capital, I'll spend a minute on this. As most of you know, the state, as part of their, I guess, their normal annual type budget process, they had a CRFP, a capital request for proposal. It was separate from DSRIP. It was not directly connected or related to DSRIP as far as it was a separate funding that they were doing. They're issuing bonds for it. But the Department of Health recognized that we have this whole DSRIP thing going on, and we're trying to transform the way care is delivered. So they kind of added a soft, informal connection in that they asked anybody who was asking for funds, if you were in a PPS, they asked for all those applications to flow through the PPS, and then the PPS was asked to take the application, rank them based on the connection to our tentative or current plans for our DSRIP goals and how they ranked in terms of importance, cost, risk, all these different aspects related to the DSRIP goals of the PPS. So there was like this soft connection, but that presents a challenge for the DSRIP plan, and the same challenges the organizations have. So as part of DSRIP, we were saying we have these 11 projects, and we said, we think there's capital, or there could be capital related to them, and the challenge was that those CRFPs, that process, everything was due February 20th. So that was even before the due date, that the April 1st for the DSRIP book report outline, if you will. So for many areas where we're nowhere near we could, as a PPS, or, we don't have the plans developed that we could say, we'd like to, put in this request for capital. So it's something that, everybody's in the same boat. So we took the approach and said to the organizations, do your best. If you have something related to DSRIP, if you can put that together and clearly define it as best as possible to put in application. So through that process, any members that wanted, or participants that are in the PPS, they submitted their capital applications. They went to do a steering committee review, which probably some of you on the call were part of that. And again, it was all about that soft connection. There was a ranking. I think we ended up submitting 32 applications, and it was about $63 million. We have no idea if and when those will be approved. We're thinking it's probably going to be in the summer sometime. They had a 4-1, is interesting. So how that relates to these DSRIP projects, that's what I wanted to talk through. So what we did is we said, all right, we don't know if those are going to get approved. So we asked on these budget templates, and as we work through the next level of detail too, we're asking for the project teams to, just note here if we did, or if there was capital requests related to that. So we asked for that on the template. And then we've asked the groups to think about if there were other capital requests that were not available or not ready or didn't go through that initial CRFP, we're asking for that to be identified. It's not anything that we have no knowledge of any new capital available under the state capital program. We have asked, and we've been given some guidance from the Department of Health, that we can, as a PPS, potentially, we're creative with it, use some DSRIP funds for these projects to pay them out to a participant. Participant could potentially use them for capital. That's about as much as we have for guidance right now. So it's still very blurry, like a lot of things. But what we had asked for, again, at the high level now, is you're developing these project budgets, is there capital pieces of it that you think you may need above and beyond? And also note what was put in through the CRFP. Because the challenge, again, for the PPS, and when I say the PPS, I mean all of us, because we are the PPS, the challenge there is, well, what if we don't get the capital? And we posed that question, too, to the DOH and said, if we have a $3 or $4 or $10 million project in for the capital and we don't get the capital, then we can't meet if we don't have another funding method, then our DSRIP goal. So we asked them, should we be changing our DSRIP plan to have some fallback? And they had said no. Put in your plans, and I think it's all something that we're going to have contingency plans built in, and we will have to adjust things as we go and work with DOH on that issue. So in summary, there, what I'm saying is, if you have capital needs, it's important, I think, to identify them, but like everything with this budget, this is in no way, shape, or form an approval of capital. It's not a grant request. It's just really preliminary estimates of what we think these projects may cost. So that's the end of the formal presentation, and then I guess we're going to open it up for Q&A, and maybe, or did you have something you wanted to add, Colleen? A question came in. Oh, okay. Okay.
So we're actually going to start out, and I'm going to unmute Lisa St. Hilaire because she's had her hand up the entire time. So Lisa, your line's unmuted.
She might have fallen asleep.
Lisa, are you there? All right, Lisa, we can't hear you, so I'm going to mute you again, but I will come back to you before we end. All right, next I'm going to unmute Brenda Stiles. Brenda, go ahead.
What's this mean?
Brenda, are you with us? All right. So I'm going to mute Brenda, and we will try unmuting Trina Listater. Trina, are you there?
Yes, I'm here.
Hi, Trina. What's your question?
I have a couple of questions. Let's see. Let me find them. Okay. In looking at this whole overall thing, first of all, I'm thinking about, I've been asking questions regarding the meaningful use side of this. Have we come up with the answer? I'm hearing an echo here. But have we come up with the answer on whether or not meaningful use is to be added into this budget? Are we just looking at whether or not the computers can do meaningful use, or do we need to add in training for meaningful use for those practices who haven't come to meaningful use yet, for stage 1 or stage 2?
Hi, Trina. This is Colleen Florio. I'm going to give an answer, but I'm also going to review the project requirements after the call and ensure that I'm correct. I believe the requirements for this particular project are really that the EHR has to be certified for meaningful use, and that the practice, of course, is achieving that PCMH standard. I don't believe that one of the requirements is to get that meaningful use. I'm sorry, I'm not up on all the jargon. Get that meaningful use certification for all the providers.
Okay, we've asked that question a couple of times. So it's just, what I'm hearing is that just the EMR has to be certified for meaningful use. And
that's my understanding, and I'm going to confirm that after. I'm going to look at the documentation and get a confirmation of that after the call.
Okay, because a lot of the practices are already working on 1 and 2, but we just need to be sure, you know, where they have to be in that stage, or if we need to hire someone to actually help them complete that.
Okay, I did have a conversation with someone on the same topic, and my understanding is that for this project, that's not a requirement. But
okay.
I'm gonna if I discover that the guidance I've just given is incorrect, we'll get a communication out to all the partners.
Okay, because we do need to know that quite a bit of additional cost to the budget.
Yes.
Okay. All right. My next question is for PCMH. The realization is, and the thought is, yes, everyone is going to make a level 3 immediately. Do we need to put in the budget, just in case, let's say one practice kind of falls behind and doesn't, do we need to put in any additional just for add-on fees? Because they might not make it the first time out. And I'm just
I see.
asking.
So the fees, that NCQA, if you have the first time, they'd have it.
Let's say they make a level 2 instead of a level 3. And they want, you know, of course, we have to get them all to level 3. Do we need to put in some additional costs just in case? Let's say one practice falls behind and just makes level 2. Do we want to add in costs for level 3?
Yeah, I think you should build your budget based on the assumption that every practice isn't necessarily going to achieve that with their first submission.
Okay. Well,
you would just want to come up with some type of, okay, my rule is I'm gonna say, you know, this percentage of the practices are, because I know you're
exactly.
Yeah.
Exactly. Yeah. That's why I'm asking. Yeah. I just want to be certain, because we want to cover all bases now for that 2017 period.
Yeah, you can go ahead and count for that.
Certainly, because that, you know, you can't guarantee what every reviewer is going to do. And that's the thought. I've worked with NCQA, I've worked with it, you know, and you want to be certain you're covering everything. Okay, the next question is, we're working with the 2017 year-end, DY3. Do we need to cover for care coordinators costs, and let's say we're looking at drivers for vans and dispatch costs and those kind of things, educators, patient educators, do we need to cover those for beyond period 3 or for the full 5 years or just for 3 years?
So that's a really good question. I mean, I know that the intent is that you cover your operational costs every year, but I see what you're saying. Like this particular project, the goal is to meet a requirement that you're going to meet in year, that you're going to meet before the full 5 years. It's a requirement in year 3, and you're saying, well then, are you going to continue to, should I continue to budget for the cost of operating as a patient-centered medical home during that 4th year?
Right, because then we have, during the, right, because as we're working with them, then, some of them that are already PCMH that are going to do recertification in the 2-year period, we've got that coming up. And then we also have, you have the 5-year period. What are we going to shoot for? Are we going to shoot for the 3-year or the 5-year period? I'm just trying to cover everything.
Right. So I would say that you can try to look at it in terms of if there's additional costs to the organization, going back to the, for transforming under the DSRIP project. So if these are costs related to getting your workforce trained or operational costs with revenue because we're changing the model for payment, then you could potentially include them. And if it's something that you do expect to cover through the revenue stream out of the patient-centered medical home, then you would not. So it's the idea of, is there an additional cost to the organization or the organizations participating, if that's really the guideline.
Right.
Yeah, I think
so
this patient-centered medical home project is a little different than some of the other projects because the stated goal is to achieve the certification.
At 3 years.
The stated goal is to implement an innovative model of care. In this one, so it's, I can say it's not, I don't believe it's crystal clear to us right now as whether the network, the PPS network as a whole, is going to fund the costs that you have to operate as a patient-centered medical home for the entire DSRIP period versus the cost that it takes you to achieve that certification during that given year. So I think, we understand the conundrum.
Yeah.
I'm sorry I don't have a clear answer for you right now. I think you should just, I would say at this point, budget for those operating costs that it takes to be a patient-centered medical home. You could put that in for the full, for all the project years. And again, we're getting that snapshot at a high level of what these project costs are going to be to your organization, but that information is going to be vetted by both project teams and finance teams. So they can raise things like this to the decision makers who could then make a determination that, so even if you have it in there and maybe some others don't, that's okay. We're not going to
Maybe if we show it up through the 3 years and then say, okay, for the additional 2, this would.
Yeah, that would be perfect.
Yep.
Okay, so.
And then again, that's an approach I would take.
Okay, so that way we're showing it the 3 years. This is what it would take during to actually obtain the PCMH level 3, and then this is what it would be for additional costs for the 5 years.
Yes.
Yes.
Okay, very good.
Okay.
Then,
all right. Was that all?
I have just
maybe one more quick one. Okay.
I'm sorry, just one more question. Okay. And maybe I should just ask Dan this, but I'm going to ask it anyway. In working with the physician coordinators, and we're just looking at this, we're trying to determine the number of hours that are needed for actually the physician coordinator. And we're trying to pinpoint, are we looking at it also for the 5 years? Do you want me to take that, the 3-year and the 5-year, the same way?
Yes.
Okay.
Yep.
Okay. All right, that answers all my questions. Thank you.
All right.
Thanks, Trina. All right, next I'm going to unmute Bonnie Oman. Bonnie, are you with us? Bonnie? All right, Bonnie, we can't hear you. I'm going to mute your line. I'll come back to you again. I'm going to try to unmute Brenda again. Brenda, are you there?
You want to do this one? Okay. Colleen has one that she got.
All right, still don't have Brenda, so we're going to go to some of the written questions. And the written question was about RHIT, give me 1 second to get the full question up. RHIT and who can or can't submit budgets, if it should be submitted at the project level based on implementation, or if individual organizations should submit their own budget templates.
At this stage, we're asking the regional teams to manage that, and that we're only expecting to have like summary templates. We're not looking for detail down to individual organizations at this point. Okay, but yeah, I'm going to let Colleen add to that.
So as Lynn said, our preference is to get a budget for the project that's being implemented in a given region, and that single budget includes the costs that any of the partners in that project might incur. So one budget is the preference. Many regions have moved in that direction and have those budgets. You're ready to serve those regions. Please pursue that. A project level budget with all the partners' costs and expenses. It's a project level in one budget. That's what we want. But I understand that I think 2 of the 5 regions, there aren't really active project leads and committee structures in place that have convened to achieve that goal. So I am following up with each of the regional health innovation team leaders to determine what communication approach they'd like AHI to have with each of those partners. So at this point in time, if you're in one of those regions where you're like, I don't know what's going on with my budget, I haven't heard anything, I'm not sure what I'm supposed to do, we will take a partner or organization level budget that's just showing one partner's cost for that project. We will take them on the partner level because we know we don't have that active committee with a leader pulling it together. But that hasn't been communicated to all those partners yet. So that might be news to some people that that's an option. And I am going to be talking with each of the leadership in the region. And I've talked to 2 out of the 5 so that we have a sense here at AHI of which regions are all set and we're getting those full project budgets, and which regions we need to reach out to the individual partners and specify that we will take that organization or partner level one. We just want to be sure we direct those communications to the right people, and that we don't confuse the groups that have already done the single project level budget.
Okay.
I hope that helps some of the next steps that are coming on that one.
We have another question from Susie. How often can we expect to have to attend mandatory meetings?
Well, there are no mandatory meetings, and okay, go ahead, Colleen's going to jump in.
So, yeah, exactly. I mean, in a way, there aren't mandatory meetings. It's difficult for me to answer only because we're covering such a broad geography, and it varies somewhat from region to region as to how often project teams are convening. But if you want to follow up with an email to me, I can find out more about what the plan is in the region where you operate. If you just want to send in on the, do you have organization on there, Heather, or can we tell? No. So that was a written question? Yeah. If you're still on the line as we're responding to your question, if you just want to type in to that question box again with what partner you're with and how I can reach you, I'll get back in touch with you.
Okay, and another question from Susie. Also, is my understanding correct that we should budget in what the last 3 years' expenses have been to obtain NCQA Level 3 plus the next 5 years?
Did that say the past years?
Last 3 years plus the next 5 years is the question for
So
NCQA.
The district fund would only cover expenditures from the district period, which officially starts April 1st. So if the question is, can you put in costs related to pre-district, then the answer is no. And I guess you could interpret it that as if my organization already expended this myself, and now other organizations are going to do it, I think unfortunately the answer is, yeah, it seems unfair, but if you already spent it, then that's good. You're ahead of the game. Hopefully you're reaping the benefits from that at your organization and from a patient level, but the district funds cannot be used to fund things that were April 1st. I will say, with the exception, we have our district planning grant that the PPS has, and a portion of that, that's where we've talked about trying to cover some costs of organizations doing planning, such as this type of meeting, and some of those funds can be used for periods earlier than April 1st in the district, but any of these budgets should all be from April 1st, 2015 on until, I think, March 31st of 2020 or whatever, 5 years is.
We have a question from Linda Beers. Is there a single project for CHAA? We have multiple agencies.
There's not is there a single project for CHA? So for certified home health agencies, there's not a single project that's a certified home health that is all about certified home health agency services, but those services are certainly part of the hospital to home project, and they may be part of work plan and other projects as well. So those home health services could be, part and parcel towards an implementation model of more than one project. The one for certain that they're in would be hospital to home. You could envision some of the other projects needing a home health component as well.
Next question is from Bonnie. Are operational costs to include existing personnel costs or only those personnel costs that are added to run the program?
So the answer to that, again, it's what the PPS determines that are going to be reimbursable. So it's not black and white. But the concept there is that you're looking at costs related to doing the transformation, related to these projects. So if you have a staff person that you're moving from one area and they're going to be now working on this, then that potentially would qualify if the cost is for, it's a true cost, as in there's no revenue associated with it. So whether the person is already an existing employee or somebody moved into that, that doesn't matter. It's really looking at what's the cost of transforming and implementing the district project.
Okay. And I'm unmuting Cindy. Cindy, you have a question? Cindy, are you with us?
Hers might have been answered from that. Or it's a different.
All right. Well, unfortunately, Cindy, we can't hear you, student box. We will make sure we get your question answered. At this time, I don't have any other submitted questions or hands raised. If you have another question, please raise your hand or submit it through the Q&A, and we'll give it another moment to see if any more questions come in. All right, we have not received any additional questions, so at this point we're going to end the webinar. A copy of the slides along with the recording of the webinar will be posted on the blog. Should you have additional budgeting questions, please email Lynn Wadley and we will include her email address on the blog posting that will go up this evening. Thank you and have a great day.